This can be classic myocarditis where the virus can be seen in interstitial cells, and sometimes, not very commonly, but sometimes the myocytes can be infested with the virus. And unfortunate part is there have been documentations where after the patient has got recovered from COVID and has gone home, after 2 weeks or 4 weeks, they have detected this virus in the myocardium. There is a suspicion that we may land up with some delayed ventricular dysfunction. So it is essential that we recognize this particular entity, and any chest pain or any cardiac element cannot be just left alone saying that this is just a COVID manifestation. So standard typhoid myocardial infarction because of inflammatory status, cytokines imbalancing the myocardial the coronary plaque, causing it to rupture and causing standard typhoid myocardial infarction. As we discussed, coronary oxygen demand supply mismatch, and obviously there is a significant, there is a lot of talk on increased thrombogenicity, which can cause.
Okay, sir, just sorry to interrupt
Just
you.
to clarify the doubts, this is I just put up this slide to know what is type 1, type 2, type 3 myocardial infarction. The standard one, which is happening because of thrombosis in the coronary arteries, which is happening spontaneously. That means myocardial plaque rupture or erosion causing thrombosis and standard myocardial infarction. This is spontaneous myocardial infarction. The type 2 we just discussed is this imbalance between. So there is no actual coronary occlusion per se, but there is an imbalance between what the myocardium needs and what is being supplied to it, especially in people who have significant hypoxia. This is going to be seen.
Okay, sir,
Type 3
sorry
is
to interrupt you.
the standard, what we can call a sudden cardiac death, where we do not have evidence. And then related to revascularization, the PCI per se can cause some enzyme like rise, which is type 1, and then stent thrombosis can cause
Okay, sir.
bypass surgery causing.
Okay, sir.
Yes.
Sir, we are not able to listen to your voice clearly. So, is it possible that you try with the video off so that we can just see, because your quality of voice is not properly audible.
So it's stop video. Is the voice better now?
Somewhat better, sir. I think there is some internet connection problem there,
Yeah,
but you can.
unfortunately. I'll speak louder if I'm okay.
Right,
Is
sir.
louder better?
Right, sir. Right, sir. Sir, you can continue.
Yeah. Okay. So where were we? So differential diagnosis of AMI can be a challenge sometimes, and this is something which we have to be worried about. Because we have to take the decision quickly as to what is to be done. Uh, Cardiac enzyme elevation is also again a bit of a problem because we can have kidney injury which can interfere with cardiac enzyme levels, and that can be a problem. So we all keep relying on this raised troponins to diagnose myocardial infarctions, but that itself is going to take a little time, and that can get affected because of kidney injury, because of sepsis, cerebrovascular accident. So remember this particular thing in mind. But if the patient has raised troponin and has symptoms which are suggestive of acute coronary syndrome and ECG abnormalities, if the patient is coming to your OPD or casualty, then if the patient does not have a strong suspicion of COVID, then he goes for common standard ECS pathways, which we have been using so far in non-COVID era also. But if the patient has significant suspicion of COVID positive or his swab is positive, then we have to decide whether he goes for invasive arm or non-invasive arm. If the patient has significant ECG abnormalities, large infarct, he goes for invasive coronary angiography and undergoes PCI as required. If the patient does not have coronary occlusion, then the patient does not have significant high suspicion, then he goes for CT scan and cardiac MRI. CT scan also show there has been some role to play by CT coronary angiography and cardiac MRI to see delayed enhancement, which is going to suspect the diagnosis of myocarditis. And here you have a role, significant role of echocardiography. Invasive coronary angiography should be performed in people who have the standard type 1 myocardial infarction. So standard ST elevation myocardial infarction in patients who have classic chest pain and low probability of COVID should go for invasive coronary angiography. These patients who have significant comorbidities, poor quality of life, frail people, have bad lung disease, they should probably be continued with medical management. Here, there is no significant role for coronary angiography. Echocardiography is going to play a crucial role in deciding who goes for coronary angiography and who does not go for coronary angiography. So generally, this will be called as a gatekeeper. It should be a focused transthoracic echocardiography. It's not like any COVID patient. We have this idea of tendency of having routine echocardiography when we are doing when the patient is getting admitted. So routine echocardiography has no role. Specifically, if you want to have specific finding, there is some suspicion, then only echocardiography should be asked for. And echo, as I said, should be a gatekeeper. So if they have a significant regional wall motion abnormality, then only they should be taken up for angiography. If they have generalized hypokinesia, then that will tell us that this is not really acute.
You lost your voice again.
Lost voice again. Hello.
Yes, it was. There seems to be an internet connectivity problem, sir, at your end.
Pushkar, let him present because some of us, we are getting his voice
Okay, okay.
properly. So let him continue.
Okay. Echocardiography will tell us about whether he goes for invasive coronary angiography or not. Then what about catheterization laboratory? We have to understand that this procedure will be required for some patients, even who are COVID positive patients. In India, a separate COVID positive cath lab is practically not possible. Only few institutes who have multiple cath labs can do that. So most commonly, this is not something which will be available in India. So people who have COVID positive status and have to go for invasive coronary angiography, they have to take utmost care. All the personnel should be properly covered, should have proper protective gear as far as possible. Any aerosol generating procedure. Now, which sometimes the patient may be requiring intubation. So now, if you are suspecting really that patient may require intubation, he should be electively intubated in casualty or CCU and then only taken up to cath lab. It's not like intubation should be performed or CPR should be performed in cath lab. You have to be very, very careful that you do not infect the lab and do not infect the personnel who are manning that particular area. So when we have to be careful taking care that we don't spread the infection to the cath lab and infect the other people who are going to be there. And once such procedures are performed, terminal cleaning has to be performed. Elective procedures have generally been postponed in most of the centers, even in US. Like a patient who has stable coronary artery disease, what we call as chronic coronary syndrome today. So elective PCIs should generally be postponed. Endovascular interventions, which generally are more or less cold procedures, should generally be delayed, or closing of or device closures like ASD should generally be delayed as far as possible. STEMI patient, even a patient who has COVID and he lands up with ST elevation myocardial infarction, the benefit should be weighed as to what he will get. If the patient has a mild COVID disease and a large myocardial infarction, he is in cardiogenic shock, then of course you have to take him up for invasive procedure, taking full utmost care that our personnel are protected. If the patient has poor COVID status, or if the impact is not very large, or if he's hemodynamically stable, he does not have significant arrhythmias, then you can still think of thrombolizing him, stabilizing him, and can be taken up for invasive procedure little later, maybe after his COVID status becomes negative. So people who have had triple vessel disease on angiography, we have delayed them for 2 weeks to 4 weeks, and then sometimes taken up for bypass surgery or triple vessel angiography. The role of ER is most important. As we discussed about ECHO as gatekeeper, even the ER performs a gatekeeper function. Here they have to quickly suspect that the patient is possibly COVID positive or possibly COVID negative. So these are the features like patient has fever, he has respiratory symptoms, he has contact with COVID positive person or a family history, family somebody suspect having COVID. Then quickly see whether he is having that. There is a strong possibility of being COVID positive. Then these patients, you quickly decide whether patient is stable and does not require hospital admissions. He is quickly sent home and advised home quarantine. If the patient needs admission, if he is stable, he stays in the waiting room, separate waiting room. But if he is unstable, then he goes in what is called as suspect area, suspect high density care unit kind of situation, and then once he is positive or negative, he is triaged into that. If the patient is not COVID, then the standard protocol still applies. So standard protocol of acute myocardial infarction or non-STEMI is continued for this. So patient who has STEMI during COVID era, patient, the standard protocol still continues. The patients still go for primary PCI depending on the requirement. The only issue is you need to decide whether he is COVID positive or not positive. The patient, again, if it's a remote area, non-cath lab available area, then he goes for thrombolysis and pharmacology kind of management. So the standard STEMI and non-STEMI protocols continue as far as even this COVID era is concerned. So the patient who has not got COVID, then they have to be taken with the standard protocol for STEMI and non-STEMI. So the patient with non-STEMI will be classified as very high risk, and intermediate risk. All of us will know about this classification, and depending on their category, they will be categorized into invasive or non-invasive. The STEMI patient, this is the Indian protocol, the CSI protocol. They categorize these people into Group A, Group B, and Group C. Group C is somebody who he is a very low probability of COVID or confirmed non-COVID, and he goes for the standard non-COVID pre-COVID era protocols. Patient who has suspect COVID or a patient who has confirmed COVID will go preferably for reperfusion strategy. If he is hemodynamically unstable, then he goes for invasive approach. Now here again, the patient, if he goes for fibrinolysis, then he is again stabilized, and later on, once he is COVID negative, then he comes in for cath lab procedure. Outpatients, generally PCI remains the standard of care in STEMI patient, depending on their time to cath lab availability. If not, if the delay is going to be there, or you are not very sure about his COVID status, then he goes for thrombolysis. So the standard protocol continues as to pharmacology approach for non-STEMI. Again, high risk, very high risk, these patients still get invasive approach. The low risk patients will get conservative treatment. Cath lab consideration, it's generally suggested that patients who have COVID positive and non-STEMI with low risk, they should generally be given conservative therapy till they are COVID negative and wait for 2 to 4 weeks, and then only take them to cath lab. We need to remember that even when we are talking of primary PCI, there are going to be significant delays because they need to be tested, they need to be taken for HRCT for quick diagnosis or quick rule out. The cath lab people will need to be having this PPEs, which itself is going to delay the procedure, the anesthetic staff, and so all these are going to delay the cath lab procedure. And so, in such situation, like in standard protocol, if the delay is going to be more than 60 minutes or more than 90 minutes between the more than 60 minutes between the two strategies, or more than 90 minutes for cath lab procedure, then probably he goes for pharmacoinvasive approach and then comes for cath lab. Now, this brings us to a point where in this era, what we thought was many people are not suffering from STEMI or ACS, but what we found out later on was that people were reluctant to come to hospital. They came to hospital much delayed into the course of myocardial infarction, and they had really damaged left ventricles. And then these are the patients who are going to present with cardiac arrest or heart failures or mechanical complications of myocardial infarction. And therefore, we need to encourage these patients that do not delay the treatment. Do not be shy of coming to the hospital. We need to tell them that whatever acute coronary care required is still happening in those acute coronary syndrome patients, and we have all those availabilities so that at least the long-term complications can be prevented. So patients definitely will be scared to come to the hospital. They don't like to come to the hospital. OPDs, they don't like to come to the hospital for treatment. But myocardial infarction is one such thing where delay is going to damage their ventricles, and they should avoid these delays. So this is here again we have a significant role to play for management of these patients. We are aware that this is there is a significant increased thrombogenicity because of COVID, and that has resulted in increased risk of stent thrombosis. But we have to take this in mind, and we have to probably use a little stronger antiplatelet agents. Now, as we know, for all ACS patients, we use dual antiplatelet therapy, where we have two choices of very strong P2 inhibitors. One is prasugrel, which was tested in Triton cricket trial. So prasugrel has been really effective molecule. It does increase the risk. It being a very potent molecule, it does increase the risk of bleeding. The other being ticagrelor, which again has proven its efficacy in this TITO trial. This is a graph showing that this is better than clopidogrel. So definite incidence of stent thrombosis has gone down. This again tells us the benefits of ticagrelor. So P2 receptors, there are these three agents which are available for oral use: clopidogrel, prasugrel, and ticagrelor. And IV agent, which is cangrelor. Cangrelor again is a reversible agent. So many times, unfortunately, in India we are not using very much, although sometimes available. But this three standard which we are using commonly, of these in ACS settings, most commonly we will keep using prasugrel and ticagrelor, especially those patients who are going for invasive approach. These are the doses which are recommended. And if the patient has bleeding or has to go for operative procedures, then these are the half lives which we need to think about. Now, this is slide which tells us that probably ticagrelor is little better than other molecules, but it is personal choice. So, if I have managed to confuse you enough, this is just a short thing I have prepared. Not a patient in this era is not all patients are COVID positive. So, patient who is not COVID positive or not suspected to have COVID, he goes for standard ACS protocol, which STEMI, where primary PCI will be indicated, non-STEMI high risk goes for intensive procedure. If the patient is COVID positive or suspected to be COVID positive, if he has bad COVID condition or bad comorbidities, he preferably goes for conservative strategy. But if he has mild COVID and invasive approach is going to give us some meaningful benefits, then he has to go for invasive approach. Now, here we should not shy from offering an invasive approach to patients who are really going to benefit out of this. So, this is what I have to tell you about ACS management. So I'll stop sharing, and we go for questions now or later.
We will take the questions now itself, sir. One or two questions from the audience are welcome.
If any questions from the audience, you may raise your hand and we can unmute.
Was I too fast?
No. No, sir, it was a very nice presentation. The only thing was, I think there was some internet connection problem, so we could not hear it properly. But otherwise, it was a very nice presentation, and we are very much thankful that it was
Can I ask
very
one
short.
question?
Yes, yes.
Dr. Sardesai here.
Yes, madam, you can go
Yes,
ahead.
Vasudha.
I just want to ask Dr. Patki, what is your experience about treating such patient in this era, basically? Any hurdles you came across?
Uh, Actually, we have done even the COVID positive patients. We have done primary angioplasties. Here, we have to be very careful in terms of protecting our people, and all of us are masked and have not necessarily all PPE covered, but N95 and face shield is something which we have most commonly used. The most important thing, probably, what we did was we covered the patient with the N95 mask. So actually, if you reduce that generation of those particles or aerosol from the patient itself, that itself reduces the chances of people getting infected. So that is one thing we did. Many times we have managed this with standard primary PCI protocols. At least for us, we were lucky that we didn't have increased incidence of stent thrombosis, but we always used either prasugrel or ticagrelor. Uh, I'm not sure whether we should be adding a small dose of rivaroxaban in addition to this. At least we have not done so far, but we have not had any bad experiences with that. People, there have been couple of patients who were in bad lung condition and we have thrombolized them and they settled very well immediately. So probably it was just mainly the thrombus which was causing the occlusion. They settled well, but unfortunately because of worsening respiratory status, they succumbed. But more or less a standard way of treating this.
Yes, so no hurdles or no complications
Luckily, yes.
occurred in this.
Yeah, luckily, yes. I think most of the labs in Pune have been doing that, and we managed to get away with primary and also.
Okay, okay. Thank you.
Thank you very much, Patki sir, for presenting this particular topic. It was needed for the physicians to know what exactly to be done during the COVID outbreak, especially regarding the ACS. I think we will move on to the next session. I will take this opportunity to thank AstraZeneca also because they have sponsored the particular talk of Dr. Nitin Patni. Thank you very much, AstraZeneca. I would request Pushkar to take the further proceedings ahead. I think Dr. Pallavi Bhargava and her colleagues have joined already. Pushkar, over to you.
Yes, thank you very much, Penulkar sir. And uh, Dr. Pallavi Bhargava and her colleague Dr. Leah Bonde is already, both of them are already here. Dr. Bhargava madam is Dr. Mayur Ramesh yet to join?
He might be in the. He's
Okay.
here with me. Okay,
Oh.
perfect. Hi.
Okay, great. So you're on from the same ID. So thank you. Welcome. So Dr. Mayur Ramesh is a senior staff physician and he's a transplant infectious disease specialist and immunology at Henry Ford Health System. Dr. Leah Monte is also an ID fellow at HFH Detroit, Michigan. And we all know Dr. Pallavi Bhargava, and now she's there at Michigan as the senior staff physician in the Department of Internal Medicine and Infectious Diseases. So welcome, ma'am. And we had this opportunity to also interact with you in the last wave that we had last year. And here again, it's been uh, it's been a whole 1 year and more where we have experienced ups and downs in the waves, and there is something new at the horizon which we'd be excited to know from you. Just today there was this news from in the Times of India where a very interesting name, Mr. Mohabbat Singh, an 84-year-old, got the first antibiotic cocktail in India. And I think we are just at the right time where things are beginning in India. And it's a pleasure to have you. You could also please introduce your colleagues so that all of us know them. And we also have Dr. Parikshit Prayag with us, who would be probably further coordinating this. Thank you.
Thanks, Pushkar. Good evening, friends. A little disclaimer. So, I'm just the familiar face and voice, and the expert is Dr. Ramesh there. So, make sure all questions are directed to him. That's one. Second is.
Pallavi is just being modest.
Leah has very painstakingly, put our experience and data together, and at like a super short notice. And we might be the lucky bunch who's hearing this, I guess, the analysis for the first time. Is that right?
Yes.
Mm-hmm.
And if I talk about what Ramesh has done single-handedly in our Henry Ford Health System, it'll eat up like 20 minutes. But what I would say is that he spearheaded the entire effort of, from March 20th onwards, of trying to use low-dose steroids at the right time. And because of that, all of us ended up saving thousands of lives. And that sort of, the burden of seeing deaths was much lowered. And that's when he dove into, you name it, convalescent plasma, to all the trials of monoclonal antibodies, to vaccine trial, Moderna. So he has I guess, a huge role to play in how we did as a system with 5 hospitals, and also shared our experience in Pune and with other clinicians in India. So I will just talk about some basic aspects and a brief overview, and then Leah will share the data that she has analyzed of our monoclonal antibody experience in the outpatient setting. And then we can open it for questions. 1 second, let me get my... Can you see? I said share screen. You can't see my slides, can you?
Pallavi, you should share screen. We don't see it.
Wait a second.
It's
It
coming.
started.
It started.
We
Pallavi
got it.
started. We got it.
Got it. Okay. So I heard Dr. Panurkar from 36 hours ago, and I heard COVID-19 and I heard cocktail. That's all I heard. So here it is. And I think by the time Leah is done talking, you'll probably be able to, say maybe which one is the Roche Cipla, or what we call as Regeneron product, and which one is what we have used in our experience. So, and after I talked to Parikshit, the plan changed from 15 minutes to 45 minutes. So I ended up making a lot more slides than what I was planning to. So we have all seen this face over last 1 year, and I guess heard him talk about this ad nauseum, mask and social distancing and vaccine. But there are people out there, I don't want to take any names, who would rather, be adventurous, and mask is not for them, or physical distancing, or vaccine. And was there anything in the horizon for them and their ever-Trumper, their followers? And it so happened that, the timing was just right. And this article was published online on October 28th last year, and it appeared in the journal I think it appeared on December 17th. And then there was an editorial by Marvin Cohen on this. And actually the second trial, so this was the first published RCT on monoclonal antibody from Eli Lilly, and that's the name of the product. And it was, for sake of convenience, we'll call it BMAB and ETI, data on those two. And the second product, which is now launched in India, I don't know if the formulation is different. Is it for sub-Q use or IV? Is the antibody cocktail by Regeneron. And Leah is going to go into the details of both, to some extent, both, and compare. You don't see full screen, right? Is it on full screen? No. Yeah.
No, we see your, oh, now we do. Now it's full screen.
So in this trial, wait, let me get this out, sorry. So the key endpoints included time-weighted average change in the viral load from baseline. That was one thing that they were looking at. Second one was the percentage of patients who ended up with either in ER or hospital. So COVID-19 related medically attended visit through day 29. And third was looking at the safety of the cocktail. So just to remind ourselves, going back to, what are the different stages and severity. So about 35 to 40% of all patients who get infected are asymptomatic. Out of the symptomatic ones, 80% would have mild to moderate illness, and about 15% would have severe illness, meaning oxygen saturation less than 94%, RR more than 30, and lung infiltrates occupying more than 50% of the lung. So that's severe. While critical illness is infection with respiratory failure, hypotension, or multi-organ dysfunction. So that's about 5% of symptomatic people would go on to develop this. Looking at the disease pathogenesis, this is where viral replication is happening. And then the hyperinflammation phase takes over. It starts somewhere where the moderate illnesses peaks when the illness is clinically severe and goes on to a patient who leads to critical illness. So the role of antiviral, as when we see the pathogenesis, is obviously very early on and leading to somewhere, in the severe disease, and very little role once a patient is critically ill. Antibody therapy is targeted towards patients who have mild illness, and the definition is presence of any symptom. It could even be fatigue or low-grade fever or cough or loss of taste or smell, but no shortness of breath. That's mild illness. And mild and moderate constitutes the large chunk of symptomatic patients. Patients with moderate illness would have, sorry. Let's skip some slides. The definition of moderate illness would be the hypoxia hasn't set in, saturation is more than 94%, but there is some evidence of lower respiratory tract disease. So that's where these monoclonal antibodies are targeted. And of course, besides the antiviral, antibody therapy, which is for non-hospitalized patients with mild to moderate illness, the other thing we have in hand is decreasing inflammation, which we do by using steroids on a timely basis at the onset of severe illness, with or without tocilizumab in a patient who's either going into critically ill stage or progressive severe illness. So it is important to remember how to define mild and moderate, because when you look at the EUA approval for the monoclonal antibodies, it is limited to mild and moderate illness. So what are monoclonal antibodies for COVID-19? They are recombinant neutralizing human IgG1 monoclonal antibodies, which are directed against the spike protein of SARS-CoV-2 virus. By design, they block the viral attachment and entry into the human cell via the ACE2 receptor. And they neutralize the virus, and they are mimicking the natural immune response. And then the antibody antigen complex would be cleared. So this is a cartoon depicting SARS-CoV-2 virus with this is the spike protein and receptor binding domain. So these monoclonal antibodies, the green thing would bind to the RBD and prevent the attachment of spike protein to the ACE2 receptors. And this is another cartoon which is showing the same thing, but with the specific, the monoclonal antibody combinations that we are talking about. So this on the upper part of the slide is the Regeneron combo, which is what you would be calling Roche-Cipla combination with imdivimab and casirivimab. For convenience, we can call it IMD and KC. And most of our experience has been with BAM alone or BMAB alone for the first few months. And then the approval was revoked for BAM. And now we are using the combination because of emergence of variants which threaten the efficacy of BMAB alone. So this is the combination that that we have been using now, and Leah would be discussing that. So the first monoclonal antibody that became approved that we used was BMAB from Eli Lilly in November 2020. In the same month, FDA gave approval for emergency use authorization of the combination, the Regeneron combination that is now available in India. And in February 25 or February 25th, about 2 months ago, as I said earlier, the single monoclonal antibody from Eli Lilly was withdrawn, and the combo is what we are getting as free supply from federal government to use for our patients on outpatient basis. So this is the timeline which I pointed out. Where do they come from? So there are two ways of, I guess, starting out with getting these MABs. So if a patient is infected, say with a new virus or an existing virus, and you are trying to come up with this therapeutics, you get the pathogen-specific B cells of the patient who has recently recovered, and you identify the genes of the immunoglobulin heavy and light chains, you recover them, and then you express them to produce monoclonal antibodies. And to my knowledge, most monoclonal antibodies are produced in Chinese hamster ovarian cells in basically factories. And a second way would be you genetically modify mice and to give them a humanized immune system, and then you inject your target pathogen, and then you harvest effective antibodies from. So that's the second way. So the first antibody, the BMAB that we used for first 3 months on our mild to moderately ill patients who were at high risk, the antibody was actually originally derived from the first US patient who had recovered from COVID-19. Is this unique to this virus? Not at all. All ID people are very much familiar with pathogen-specific single target monoclonal antibodies for HIV, influenza, RSV, MERS-CoV, and Ebola and Zika. In fact, RSV and Ebola have shown to have good efficacy in human trials, and RSV or monoclonal antibody against RSV has actually FDA approval. I don't know if Parikshit and Ramesh have used in their population, immunocompromised population. So what are we trying to achieve by giving monoclonal antibodies to these patients? We are trying to boost the immune response. And how are they different than giving a high titer convalescent plasma? So they have singular activity against a predetermined target. And convalescent plasma would have polyclonal antibodies from patients who are convalescing from that particular infection. So the titer may not be that high that you can achieve with, and of course, the target activity is sort of diluted. So besides boosting immune response, it can have a variety of other, positive effects. And that's what our ex-president felt like, a Superman. And you could see him with his high BMI and age at least 70 and above, how well he did with the Regeneron infusion. Why not a single agent? Why a combination? So as I said earlier, our first 3 months, we were using a single agent from Eli Lilly, BMAB. And the other company, which is the product you would be using, they actually, to start out with, came out with a combination because of their understanding and experience that you can have emergence of treatment-resistant mutant virus when single antibody is used, and that was extrapolated from experience with RSV, monoclonal antibody. And also that the experience with preclinical studies confirmed that the cocktail protected against rapid emergence of such mutants, which was seen with a single agent. So the combination did better, and these are preclinical studies. And then in non-human primates also, they did in vivo studies which demonstrated profound antiviral activity of the combo, Regeneron CoV-2, in reducing viral load, both when they gave it in a prophylactic context and also in a therapeutic context. So exposure, no infection, it worked, and exposure, infection, and then they gave early on and it worked. So Rudy Giuliani got the product that you would be using, and so did President Trump, and Chris Christie got a single. I don't think he got a combo. He got from Eli Lilly BMAB, which we have, I guess, the greatest experience with. So what is the evidence that monoclonal antibodies work besides the non-human primate model that I talked about? So in vitro assays clearly show reduction in the viral load, both with the BMAB as well as the combo product compared to placebo. And the largest reduction in viral load with monoclonal antibody combination was seen in patients who were seronegative at baseline, which means when you used it early on. So their innate, their humoral system had not produced antibodies against SARS-CoV-2. So they were seronegative, and high viral load had the maximum benefit, which may also suggest patients who had higher, I guess, more severe disease, higher viral load, and early on is when you had the greatest benefit. This is from actually the brochure of the Eli Lilly, the combination study, which was phase 3 Blaze 1, which demonstrated reduced risk of death and hospitalization by 87% in patients who got combination antibody from Eli Lilly. And as you can see how, so this is the placebo in the gray one, how the proportion of patients who ended up in the hospital is significantly larger in placebo versus the combination group. And the effect was even more profound in actually the group which got the lower dose. So this comparison is of BMAB with 2800 milligrams combined with ETI 28 milligrams. So there was no advantage to using the higher dose combo for the Eli Lilly product. So that's why the dose which is approved for use and what we are using is 700 of BMAB with 1400 milligrams of ETSI. This is the first RCT with the combination with the Regeneron combination published in NEJM, which I think Leah will also allude to, and just the total number of patients enrolled was 799 with the placebo 231, 215 got the lower dose, 219 got the higher dose, and this was the sum total of these two, the pooled antibody group. So if you look at the proportion of events in the placebo versus the groups that got combination antibody, it's about half the number. But this is for all participants. But when they looked at patients who were at higher risk of hospitalization from their risk factors, the effect was more profound, 9% versus 2 to 3%. So the reduction in the risk was more magnified in patients who were at high risk. And as far as median time to improvement of symptoms, there was not a big difference, 5 days in the combination versus 6 days with placebo. And safety in terms of infusion reactions or serious adverse effect, no significant difference between placebo and the combination. I wanted to show this as well as the other trial, which with the combination Regeneron product, which were pulled out both for for futility reasons. So when they looked at efficacy of BMAB in hospitalized patients with COVID-19, it did not show any benefit. And they enrolled about 314 participants, and then because of lack of efficacy, this trial came to an end. Likewise, experience with the Regeneron combo product in hospitalized patients. This was, I think, stopped in October last year when they looked at patients who required oxygen due to COVID-19, meaning the disease was more advanced. There was no benefit, and there was some signal that there might be safety issues, and the risk-benefit ratio was not favorable. So this was stopped as well. So who are the patients that we would consider for monoclonal antibodies? So first of all, the requirement is you have to have a direct SARS-CoV-2 viral test which is positive, which could be rapid antigen or PCR. They cannot be asymptomatic. They have to fall in the category of mild to moderate disease, and we looked at what defines mild disease and what defines moderate disease. And age can be as low as 12 years, so pediatric population as well, 12 years plus, and the minimum weight requirement is 40 kgs. And this is the criteria from, I guess, as far as health problems are concerned and BMI criteria. So the original BMI criteria that we were using was BMI more than 35. And in May of just actually this month, they have reduced it to more than 25. So there is widespread availability now of the monoclonal antibodies. And they were able to expand the use to people who are still at significant risk, not as high as BMI of more than 35, but and then as the data accumulated that pregnancy is also a risk factor for progression into severe disease, That has also been added this one. So these are the two major changes to the original criteria. And Ramesh, is there anything that I'm missing which is added since?
He had to step away, but he'll
Okay.
be back for questions at 12:15. But we'll be covering the trials, and so please focus on the. But this is it. This is for now.
Okay, so BMI more than 25, pregnancy, presence of chronic kidney disease, a diabetic patient meets the criteria. Any patient who's on immunosuppressive treatment or has disease, for example, CLL, which affects either ability to respond to a vaccine or if exposed, would progress into severe disease, they would qualify. Anybody who's 65 or above, or if you are more than 55 and less than 65 with any of these health problems, cardiovascular disease, hypertension, COPD. So the criteria are pretty loose. And for younger people between 12 to 17 years of age, it's not an absolute BMI number, but 85th percentile for, if they are at 85 or above percentile for their age and gender, they would qualify. Presence of sickle cell disease, congenital or acquired heart disease, any neurodevelopmental disorders, if they have, trach dependence, gastrostomy, or they are on any amount of positive pressure ventilation, that qualifies. Presence of asthma or reactive airway disease, that requires daily medication. So just a history of asthma, not that high, I guess, a risk factor for progression, but somebody who's requiring daily treatment for control. So this is another thing, while we just went over the list of risk factors. So this is a COVID network surveillance where they're looking at patients who ended up hospitalized with COVID-19 disease and what were their risk factors. And this clearly showed that as the number of risk factors increased from 1 to 2 to 3, the rate ratios basically multiplied. So if you had one risk factor, the unadjusted rate ratio almost doubled. And if you had 3 or more risk factors, you were at higher risk of ending up in the hospital with severe disease. And age, being a male, non-Hispanic, Black, and there were other race and ethnicities which were independently associated with higher risk. So I'm not sure what formulation and I guess what strength is what is now available in India, but it can be in, I guess, four separate vials with 2.5 cc each and 300 milligrams, so which makes it 1200 milligrams, or a single vial of 1300 milligrams to be reconstituted and mixed with equal amount of the second monoclonal antibody. So KC and MD together, equal amount. Once you reconstitute the cocktail, it is stable at room temperature for about 4 hours. So it cannot be left outside for longer than that. And that also includes includes infusion time. And as I've heard that it is one package is good for 2 patients. And if you're going to reconstitute it, then I guess you'll have to refrigerate if you don't have a second patient to infuse it to. But so when you get ready to infuse the next patient, bring it to room temperature for about 30 minutes. So just equilibrate the temperature. And then the reconstituted solution is good for 36 to 48 hours at just the refrigerator temperature, 2 to 4 degrees. So the initial, I guess, recommendation for the Regeneron combo cocktail was about an hour, but from what I read now, it can be as short as 20 minutes. And there is also subcutaneous formulation that has been studied. And I think Dr. Ramesh was part of that trial for prophylaxis study with the combination. The patients have to be observed during infusion and vitals to be checked every 30 minutes unless they're reporting, I guess, any complaint, in which case more frequent. And 1 hour is what is recommended as the observation period once the infusion is over. So minimum infusion time 20 minutes and an hour's wait after that. Infusion related reactions, Dr. Ramesh can tell us, because he has supervised majority of the patients who actually received monoclonal antibody in our ID clinic infusion area. So these, just like with any, I guess, monoclonal antibody product, we can expect these reactions, but these were really uncommon. And if it is something that is significant, you definitely want to slow the infusion. And if you can't abort the, I guess, side effect, then discontinue the infusion, and with or without use of supportive treatment, which could be paracetamol, Benadryl, or if it is nausea, then some anti-nausea medication. So these three things with steroid and of course epinephrine would have to be kept handy. So what kind of infusion related reactions were seen in this first RCT with this combination, the Roche-Cipla combination? So the total number of infusion reaction placebo was single. With the lower dose, which is what you would be using, there were 0 infusion reaction, and there were about 262 patients. And with the higher dose, which is not what you would be using or is being used, there were total four infusion reactions out of 258 patients. So it's a low frequency, and out of those 2, the drug had to be discontinued, and a single case of anaphylaxis in this group of almost 800 patients. Serious adverse effects with this product. So placebo saw about 2.3%. The dose that you would be using about 1.6%. And none of these serious adverse effects were thought to be related to the study drug. So which population you can't use this cocktail for? Hospitalized patients due to COVID-19, you cannot use it, because that by definition is severe disease, and the studies and trials have not shown it to benefit. Patients who are on oxygen therapy because of COVID-19, it's a no. Patients who have baseline increase, if they're on oxygen supplementation at home at baseline, and there is an increase in the requirement, that's again a group that you can't consider this, because it's just indicative of progressive or worsening hypoxia. And this is, I guess, available, the fact sheet for all healthcare providers for this product as well as the Regeneron product. So what are the key messages for monoclonal antibody use? You have to test early, because the greatest benefit is when given within the first 3 to 4 days. Because as you have all seen that sometimes you're seeing hyperinflammation as early as day 6 and day 7 and hypoxia setting in. So test early at the onset of symptoms and make sure you know what was the day 1, because there are patients who have headache, body ache, sore throat, cough, but the day 1 is counted as the day of fever. Unlike influenza, where the definition is abrupt onset of fever, cough, and or sore throat, they happen together within hours of each other. Patients can actually tell you like exactly when the fever started. That's not true with COVID-19. Fever may not be the first symptom, so it's very important to know the day 1, so you don't end up using it for patients who, who are already in the hyperinflammation phase. So that's important. So recognizing this is the commonest cause by far of fever or upper respiratory illness. So recognizing, testing early. And there are online tools available. You can easily, there's an infusion locator finder for population in the US. So they can go on the website, which is run by Department of Health and Human Services, plug in their age and the questions they ask, and then they will not only tell you the location of the closest location to your residence where you can get an infusion, but also do you qualify or not. So early testing, assess if they are at high risk, and administer it as soon as possible, and preferably within 3 days from onset. But the package insert will tell you you can give it up to 10 days from onset, as long as they're not hypoxic. And monitor carefully during the infusion and for an hour. And so even though these patients, most of them are likely going to do really well with their symptom resolution, most patients feel better in about 2 to 3 days. But they have to understand that based on the severity of the disease and symptoms, they still have to follow the home isolation and quarantine guideline. So if they have mild disease and they're symptom free, they can be out of isolation by day 10. But getting this is not a ticket to, being out and about, because they might feel well in a couple of days. And do not use in patients who are hypoxic. And if you have a patient who's admitted for an unrelated reason, but is found to be COVID infected, they were incubating, then at least here we are allowed to use it if they meet the other high risk criteria. And that's all.
Madam, before she takes over for technical announcement, we may have to end this particular link at 10:15 Indian time, and we have already sent. We are going to send a new link of Zoom at
Okay.
10 p.m. Indian Standard Time. We have sent a new link to you, the speakers from US, already on your mail. But this link is going to be continued for half an hour more. We can just continue from here. We can have presentation of the next speaker. Parikshit, you can take over.
Yes. So yeah, good evening, everyone. I think, Leah, you probably would want to present your data first, and then we can go to the questions and answers.
Perfect. Yep. I'm sharing now. Can everyone see the blue slides?
Yes, we can.
Perfect. Okay, so thank you, Dr. Bhargava, for giving us that intro. Dr. Ramesh really wanted to have everyone take away from that the criteria for who should get this, and also the fact that you can be very young and just have a high BMI and COVID and get this, or that even if you're over 65, even if you have nothing else wrong with you and you're thin, you should get this. Provided you're not hypoxic. And that's the key, is once you're hypoxic, once your SpO2 is less than 94, you should be admitted, you should be getting remdesivir and oxygen and not monoclonal antibody. So I'm just going to take probably the next 15 minutes to talk about the clinical trials versus the real world experience about hospitalization rates, because ultimately a lot of these trials were scientific, and they looked at things like viral load log reduction at day 7 or day 11, or symptom reduction at day 7, 11, or 22. But ultimately, when your health system is on fire and you're running out of ventilators and people are dying, the whole point of this is to keep people out of the hospital, to keep those people who are not yet hypoxic, who find out they have COVID, from becoming the people that are intubated and dead. So I'm going to talk just briefly about the hospitalization rates in the 3 main trials, and then real world hospitalization rates that have been seen in the US. And currently there's only 2 published papers, and then our data that we have about the real world using these, and then briefly touch on caveats with variants and emerging data about B1617, which is the variant that's currently dominant in India. Oops. So this is the phase 2 BAM Blaze 1 trial. Just the takeaway from this is just that compared to placebo, about 1.6% of the people who got BAM were hospitalized versus 6.3% of those who got placebo. So right away in the clinical trials, they saw lower hospitalization rates in patients who got monoclonal antibody. And again, this is an ideal population. This is a relatively healthy and young population. And this is a population that's ideal in a trial in that they were very early in their symptom onset. So this is a best case scenario. Later data of the phase 3 Blaze, where they were giving the combination, the BAM ETI, as well as the BAM mono versus placebo. I have the hospitalization rates there. So 1%, 1 to 2%, depending on the dose of BAM that you got, 1% in the combo group, and about 6%, 5.8% in the placebo group. So again, we see rates around 6 or so percent in placebo, where if you don't get anything, and then hospitalization rates around 1%, 1 to 2% in the ideal trial in the people that did get monoclonal antibody. This was followed in December 2020 by the Regeneron data. The drug is called RAIN-CoV-2, which is the CASI IMDEV combination. And in that trial, again, similarly, placebo, they saw around 6% of those patients hospitalized, where the people who got monoclonals were being hospitalized around 3% of the time. They didn't give p-values and the confidence intervals crossed over. So it wasn't statistically significant, but it was half of the amount. So it's important to keep in mind. Now, coming to the real world, some of the first data that came out of Chicago, this was from Northwestern University, looking at patients who got BAM alone versus a control group of patients who got no drug, but were eligible to get monoclonal antibody. They found that the hospitalization rate in their monoclonal group was around 7.3%, whereas in the control group, it was around 20%. So again, this just illustrates how much higher the rates are in the real world compared to a trial, but that ultimately it's showing that better than placebo, and that a significant amount of hospitalizations are being avoided by giving these antibodies. Next is very recent data that came out last week out of Pittsburgh, and these compared bamlanivimab alone to a group of propensity matched non-treated patients. They actually had over 10,000 control patients that were eligible, and then they propensity matched them. So the control group was around 1,000. And overall, hospitalization rate in the BAM group was around 6.5 versus 14% in the control group that received nothing. So again, you can see that the hospitalization rates for the monoclonal antibodies in the real world are not nearly as good as in the trials. They're not nearly as low as 1 or 2%. They're, around 6 or so percent, but still much less than the people who were eligible and did not get any monoclonal antibody therapy. So coming to our experience in Detroit, we have quite a few people who got monoclonal antibody starting in December and cutting off in April. We have 294 who got BAM, and then starting on the 27th of March, we began giving the combination therapy, and we have 349 of those patients. And you can see that we had an additional surge in Michigan around late March, early April, where we were giving huge amounts of the antibody, up to 20, 30 patients a day, whereas previously earlier in the winter, we were giving, 4 and 5 doses a day, and trying to keep up with the demand because of the amount of people getting ill. Overall, 312 people were scheduled for BAM infusion, and 385 were scheduled for a combination infusion during that later period. we did have some patients who were eligible and scheduled and just didn't show up. And a couple people, one in each group, declined to get the infusion at the visit. They just came and changed their mind. But it's important to note that, there were, 5 patients in the BAM group and then 12 patients in the combo group who had gotten too ill to receive the infusion. So even that small wait of a day or two between getting tested and being referred and getting to the infusion center, when they arrived, they were already hypoxic. So at that point, that's not a patient that can get monoclonal. That's a patient that has to go into the hospital. So we had 5 of those patients in the BAM group and 8 in the combo group. And there were additional 4 patients in the combo group that had been admitted to the hospital due to worsening symptoms prior to receiving the infusion. So overall, we had about 294 and 349 that had gotten each combination. For us, this isn't as important for you guys where you have more homogeneity in your population, but in the US, we have a lot of issues with higher rates of death, hospitalization, and bad outcomes in patients who are non-Hispanic Blacks. So this is just showing that our groups were roughly similar and that any differences that might be seen weren't due to race being different. Overall, our patients who received the infusion were in the middle age group. They were 58. And the differences between the 2 groups were kind of driven by the fact that people later in the pandemic tended to be younger and heavier. So they were patients with a lower median age and more likely to be morbidly obese or have a BMI above 35, which was the criteria used at the time in the EUA. This is going to be something that you see in a lot of trials with any COVID drug, is that as you have people being vaccinated, your population changes. So when at first you're only vaccinating healthcare workers and older people, then the people who become sick are suddenly younger people. So that kind of explains some of these differences since the combo was being given later. But overall, race was similar, and this is a much heavier, sicker population than was seen in the clinical trials. Again, our groups were pretty similar based on comorbidities because the group that got BAM alone was sooner in the pandemic. They were older, so they tended to have slightly more MIs and solid organ cancers compared to our combination group that was later in the pandemic and slightly younger and obese. Overall, a majority of our patients that were treated, and this is similar to the clinical trial, I'll show you a table comparing all 6. But most of the patients that are getting this are mild disease. So they are not short of breath. They just have loss of smell and fever or some symptom. And again, none of these patients are hypoxic. So even the moderate disease patients, that's just a patient who has respiratory shortness of breath, but still not hypoxic. So overall, the high 70s to 80% of the patients getting this have mild disease. Majority of the patients' symptom onset to infusion time was median of 5 days. Okay, the onset was slightly shorter. We were able to get them the infusion quicker in the BAM group, and it took 6 days, a little longer in the combination group. But again, this just illustrates how important it is to come early. And in the clinical trials, again, where we're seeing median time to infusion of 3 and 4 days, whereas in the real world, we're seeing closer to 5 and in some cases 6. It's an important point to keep in mind. And ultimately in the red box, there are COVID-related 30-day admission rates. So overall, 7.5% of our patients who were treated with one of the 2 drugs were hospitalized. This was not different whether they got the combo or the BAM alone. And then although we don't have a control group for placebo, we just wanted to show you guys this because it's important to keep in mind. Of those 54 patients who were eligible and who were scheduled to come to our clinic, but they did not get the infusion, 18 of them ended up being hospitalized, which is 30%, over 30%, and actually 3 of them died. So you can see how those numbers are much higher than, these numbers in our group that where we only had 4 patients die, we only had 7.5% hospitalized. So again, although this isn't powered statistically to be a true control group, it's something important to keep in mind that is in line with what those other real world trials in Chicago and Pittsburgh have seen. So kind of putting everything all together, in the orange there, you have your clinical trial hospitalization rates of 1.6, 1, and 3%, depending on the formulation. And then the real world rates in Chicago, Pittsburgh, and Detroit that are ranging 6.5 to 7.5%. Again, just showing how the populations tend to be sicker, heavier, more obese, have more comorbidities, and are older in the real world compared to the clinical trials. So you can see the median age is higher in the real world trials, the median BMIs are higher, and patients in general are just sicker and more ill. And that probably explains why we see higher rates of hospitalization. And then again, keeping your mind on that days since symptom onset, that second to last row in the clinical trials, in an ideal situation where you're getting people infusion within 3 to 4 days from symptom onset versus 5 to 6 days in the real world. And that's a really important thing for you all to keep in mind as you try to use this effectively for your patients. Now, variants are interesting. This is data derived from some of the EUAs where they've tested in vitro different variants to the different monoclonal antibodies. So India is fortunate in that the combination that they're getting in RAINCOV-2 by Regeneron isn't affected by any of the known variants that are currently circulating in the US. Now, BAM alone is affected and has reduction in susceptibility to all of the variants outside of the UK variant. The BAM etesevimab combo also has reduction in the non-UK variants as well, although it's not as severe a reduction in efficacy as the BAM alone that we see. So I have on the next slide the fact that our variants at least in Michigan in the US is now primarily a B117. So, our BAM and our BAM etesevimab is not probably affected as much in our region because our B117 patients are still, able to have susceptibility to these drugs. But if we were in an area where we had more Brazilian or South African variants, we would have to be using RAINCOV-2. And that's why it's fortunate that India will be getting that formulation. You can see this is the Michigan, this is just from our local data, the rise in B117 in red. Each bar is a week. So starting in early May on the far right, you can see that by early May, a vast majority of our isolates were actually B117, and the wild type SARS-CoV-2, which is in light blue, is now only a small percentage. The one that's the most important to keep our eye on in the US is the pink variant, which is the Brazilian P1. And there are many states currently who are now stopping shipment of BAM formulations and switching to Regeneron formulations because of higher rates of the P1 variant. So as of this week, Illinois, Massachusetts, Nevada, Arizona, and California have all halted shipment of Eli Lilly. And we'll be doing the same thing here too once our rates of P1 get above 10%. Now, I know in India, the big concern is the B1617, and none of these trial data, none of these real world data that I showed you are in patients with a primarily B1617 variant subtype. So the best we have to know about how these drugs will work for you guys is unpublished, unpeer-reviewed German data that just came out 20 days ago. They did some in vitro studies where they were trying to inhibit cell entry with the different monoclonal antibodies of the different variants. The B1351 is the South African, and then the B1617 is the one originating from India. The important thing to keep in mind is that the Cassie-Indevimab RAIN2 combo that you'll be getting, the second one there, in this in vitro data, it appeared to effectively inhibit entry of either one of those variants. And it was fine. And I'll show figures on the next slide. Bamlanivimab alone failed to prevent entry of either the South African or Indian variant. And the combination, although it was somewhat effective in inhibiting the B1617, it wasn't as effective as the RAIN combo, and it was not as good as stopping that one as it was to wild type. So the takeaway from this is that, you know, caution should be used with BAM alone. It really is probably not going to be effective for B1617. The yellow box there around the combination that we're using in the States, in many states, it probably is less effective. You can see the yellow line, which is the B1617 variant, is slightly shifted to the right. It should be where the black line is. Whereas the RAIN-CoV-2 in the green box, which is the combination you'll be getting, appears to be equally effective at inhibiting both wild type B1351, which is South African, and the Indian variant B1617. So again, this is not peer reviewed and this is not in patients, and we don't know how this translates to how many people will be saved or not hospitalized or not dead, but at least it's encouraging that it's inhibiting cell entry in the Indian variant. So in summary, real world hospitalization rates in these monoclonal patients are ranging between 6.5% and 7.5%. The real world time to infusion from symptom onset is around 5 days versus 3 days in the trials. So early identification of eligible patients and rapid referral is very crucial. It's a moving target as the population who's getting COVID changes and as the variant population changes. Overall, caution should be used in populations with a high prevalence of non-UK variants, including the Indian variant, with the BAM etesevimab combo. Whereas with the RAIN-CoV-2 combo, at least in vitro non-peer-reviewed data suggests that the RAIN-CoV-2 is inhibiting its entry, and the BAM etesevimab combo may inhibit it, but less effectively, although real-world outcomes are unknown. And so with that, we will stop sharing and take any questions.
Yeah, thank you so much, Leah. That was wonderful. So I'm going to start off with a question for Dr. Mayur Ramesh, and it's always great to have you, and Dr. Pallavi Bhargava. And I'll come, Leah, to you a little bit later because you really know the Indian healthcare system. So Dr. Ramesh and Dr. Bhargava, one important thing we saw in these trials that at best this was prevention of hospitalization, and the difference was 3% versus 9%. So if you look at the numbers needed to treat to prevent hospitalizations, they are going to be about 15 to 20. Now this combination is going to be about 60,000 per patient in India. So and these are trials, like Leah mentioned, these are trials without the Indian variant. I mean, some patients could have been there, unknowingly. The other part is we don't sequence as much in India. So, if the variant changes, we are not that quick in picking it up. So now the fact that, we need about 15 to 20 patients to be treated to prevent one hospitalization. Each patient needs to be given a drug which is worth 60,000 rupees, and trials which don't include the Indian variant. And not as much of genomic sequencing going on in the country. So how do you think would be the cost effectivity of these monoclonal antibodies in India?
Very good question, Parikshit. First, a word of shout out to Parikshit in Pune is you got one of the best infectious disease doctors that I know in Pune. This young man is just really amazing and extraordinarily well-read and very well-experienced and an amazing infectious disease doctor. Thank you. Thank you for being there and do what you do there. So the number needed to treat is somewhere much lower. It's about 8 in the real world data. Obviously, it's not true trials because we pick the highest risk population. in all the real world data, they picked up the highest risk. So you reduce the number needed to treat by picking the highest risk. As you very well know, as Pallavi pointed out earlier on, is the majority of the patients are going to do okay if you don't do anything to them. Just if you just leave them alone, majority of them will do well. But the highest risk people are the people who are going to progress into the inflammatory phase. And this one, meaning the older people, the obese people, the comorbid people, and stuff like that. So if we narrow it down to the highest risk people, the number needed to treat will be much lower, probably half of what you described, maybe more like 7, 8, somewhere in that ballpark. True, you're not sequencing or sequencing less. They are sequencing in India, but definitely lesser than what you would want to be. But good news so far is the Regeneron cocktail, at least in vitro, using pseudovirion data in vitro, seems like you may be okay at this point of time. So I think India is starting that step for monoclonal antibody in the right step. True, there's shortage of medications. They're only, I think the first shipment is about 200,000 doses, is my understanding. And you are probably having probably the same number of cases a day. So it is tough. How are you going to equitably distribute? And I'm sure people who have more money will somehow ask for it and things will get. But as doctors, we got to do the right thing by giving it to the highest risk category people to prevent hospitalization. The key element that I would suggest is please use early. And the second key element is people sometimes forget that their symptom onset, the patients will forget that, and as doctors, we need to figure it out, and it's very important. Fever is not the main symptom onset. The symptom onset is just fatigue. If something unusually different than before, and that is the day of symptom onset. If you assume fever is a symptom onset, you would miss another 2-3 days extra. So it's extremely important that we understand what is symptom onset, and that's important because if you're hitting at day 6, 7, you're already hitting into the inflammatory phase, and beyond that time point, antibody is not useful. So we cannot be using 7 days, even though the EUA and US says 10 days. I would rarely use antibody. I would like to use it within the first 4 days if possible, preferably, and worst case within the 7 days. I don't want to use it beyond that because that is not the role for it. Beyond that, the patient is probably hypoxic and needs to be treated differently. So that's sort of the gist that I would encourage Indian colleagues to do.
Ramesh,
Absolutely.
I just wanted to highlight, our job was made so easy. So one has to kudos to President Trump that he said, what I got, I felt like a Superman or I felt good. Every American who needs it, this should be made available. And actually, so for the burden of, who will end up with the bill, all of that was totally gone. So we were able to do strictly by, looking at the criteria and of course trying to convince people who are not feeling too bad isn't easy either. So that, I don't know how Ramesh did all of that. But I think we didn't have we didn't have to deal with the financial part of it at all.
Right. But Dr. Bhargava, your take on the infrastructural constraints, I mean, a lot of the COVID patients are seen in smaller setups and smaller clinics. So, to have an infusion of about 15 to 45 minutes and then 30 to 60 minutes of observation in some of the smaller setups. I'm not talking about, hospitals like Dinanath or KEM or, Ruby Hall. You're well versed with the situation in Pune, but your take on the infrastructural aspects of rolling out this program in India.
Yeah, I mean, first of all, I'm more worried about ability of the physicians who's the first to hear from a patient that he's unwell to understand, the window of opportunity. First of all, I'm worried about that part. How would you go about educating physicians about what we discussed first, right? Because I think you were also expressing fear that it will end up getting misused in some way, either given too late. So yeah, that's my biggest fear. Other than that, I guess here also FDA has allowed now to use, earlier there was a lot of resistance, our ER refused to do the MAB infusions because they were super busy and they didn't want another, patients waiting for hours and dealing with that. So a lot of hospitals set up tents outside ER and started infusing, so that precious time is not wasted. So patient doesn't go home and come the next day. That's what was happening with our infusion center. Like patient would go to ER or an urgent care and then the referral. So 2 or 3 precious days elapse. And then they allowed it for you to infuse in like, so they are increasingly loosening the places where you can do it. And there was a lot of concern about even in the infusion center. So Ramesh used to actually go there at 5 p.m. So the nurses used, once your regular patients were done with your IV antibiotic infusion, because you didn't want to have patients who had COVID-19 come into the same area. So there were a lot of logistic concerns we had, and it was very challenging. But I think that part, once they started doing, the nurses got comfortable. They were uncomfortable about, I guess, exposure risk, being with the patient in the room, observing them, all sorts of fears. But yeah, it will be a huge, and you can't say that the patient should come to referral center because, you're talking about more time, losing more time.
Right. Yeah, I was just talking about this with Bharat, this afternoon, or I guess earlier this morning, and we were deciding how to do it in Dinanath. Maybe have a couple of separate beds for that on the COVID floor. Depending on how many patients we would get in the day. I mean, right now, second wave is dying down quickly in Pune, but if and when we do get a third wave, or when we have these sort of patients, even right now, how many beds we would need, and what sort of infrastructure would need to be created. But fair point, Leah. I wanted to ask you something, since you've seen these patients, upfront as a first-hand experience, as an ID fellow. What were your observations when the infusion times were shortened, and what sort of infusion times were you using? What were the adverse effects and the challenges when the infusion times were shortened? And did you have any experience with the other formulations, the non-IV formulations, for example, the subcutaneous formulations?
We did not do any subcutaneous formulations. We had, out of our 600 and some patients, no anaphylaxis. There were about, I would say, 1 in every 20 patients who had nausea, who required a dose of ondansetron. And I think there were maybe 3 to 5 patients who had itching, but nothing was given to them. They were just told to take Benadryl when they came home. So overall, the burden on the clinic, even when the infusion time was shortened, we didn't see any severe reaction. And all we saw is maybe like 3 to 5% of nausea. And there was only 1 patient out of the 600 who ended up, I think, having a rash bad enough to where they came to their doctor and had a rash. So the rates, although the hospitalization rates are not as encouraging as the trials, they're higher in the real world. The nice thing is that at least the adverse effects in the real world don't seem to be higher either. So the low numbers of adverse effects that are seen in the trials, that actually seems to be low as well in the real world.
Leah, I think Dr.
So
Ramesh,
in general, even shorter infusions were well tolerated.
Yeah. And, Dr. Ramesh, I can see in the notes when I go through each patient that I review how many times he was called, if there was a problem. And that was the only thing I saw with any type of commonality was nausea. There weren't many patients who reported issues at the infusion center other than nausea. But there was 1 patient that had a rash after the infusion. Yeah.
Right.
I think Ramesh was part of it,
Dr.
with the sub-Q formulation, not for our patient, but I think the Regeneron combo was studied as a passive vaccination in patients who were exposed, like household contact. So I think he has experience with that. Maybe he can share.
Right, but he had to go, so he's not here, and we did not give any of that to any of the patients we saw in our hospital or clinic. So that's the sub-Q. We don't have data on that.
Right. Dr. Bhargava, it was interesting that, for the casirivimab studies, their primary endpoint was reduction in viral load. And this is for you as well, Leah. Whereas in the BLAZE trials, the primary endpoint itself was COVID hospitalization. Your thoughts on, why these endpoints were structured differently for a very similar drug? Because, generally trials are built around to satisfy the primary endpoints, and then the secondary endpoints being satisfied is sort of a corollary of the design of the trial. So, I mean, I was curious to know why they had different endpoints for the, bamlanivimab combination and for the casirivimab combination trials.
I think overall, that they wanted to have endpoints that they could show a difference. So it's a lot easier to show a difference in viral load reduction and symptom reduction than hospitalization, because hospitalization is affected by so many other things, including your socioeconomics and what your resources are at home and how confident you are being safe at home with your support system and family versus, not having that and needing to go to the hospital. So that's why a lot of the trials, like the hospitalization, which is ultimately the most important thing, was only a secondary or tertiary endpoint, I would guess. Because I mean, the phase 1 trials are still very basic science and they were about establishing a dose, but they wanted to show those viral load reductions and, again, like symptom onset reductions. In the Regeneron data, you see they're looking at symptom reductions as pooled conglomerates at day 7, day 11, day 22. But ultimately, none of that really matters if you're not stopping people from coming to the hospital and dying. Yeah, someone asked about prognosis. So risk factors associated on univariate and multivariate regression with a likelihood to come to the hospital was looked at in the Chicago paper. I believe it was like the presence of any cardiovascular disease and age over 65 were associated with more likely to be hospitalized, but I'd have to double check, but that was looked at in that paper. We did univariate and multivariate regression on our patients and nothing shook out as far as something that made them more likely to be hospitalized. Nothing came out, but there was something in the Chicago paper.
Not even, I guess, time from onset.
No.
Okay, I'm just interrupting for a second, Dr. Parikshit. Apologies for that. I know we are in mid-air right now in the flight. We just have to take a small emergency landing and change flights and take another Zoom meeting here. So what I'm going to do, I'm going to do it easy. I make it easy for you. I'm posting this particular link in the chat box. The meeting over there has already been initiated by the the owner there. So you might just leave this meeting and start going there. It'll be a smooth transition with a minimum layover time. Yeah, we'll see you there in the meeting. You can click on the link there. Plus, for those who are on WhatsApp, all the people, all our friends from Pune, they have the link in the WhatsApp as well. Yeah. Yes. All those in this meeting can please click on the link in the message box to go to another meeting. We are just changing flights.
So if the Regeneron is going to work in such patients, or is there any experience of use of Regeneron in such patients? Yeah. If somebody my main concern here is that someone we have seen many cases someone has had the first dose of the vaccine and then in 4 to 5 days the patient has turned positive. Maybe when we have